So the Heart Rhythm Society 2021 was in Boston this year, and it was a really welcome meeting to see friends and colleagues from across the country outside of a virtual format. It was offered as a hybrid format, but just the interaction and the idea exchange was fantastic. And I'm really hoping 2022 we'll see each other a lot more to help this discussion and dialogue to improve the field of electrophysiology. So taking a step back, most ablation means destroying cardiac tissue. And, it's always a trade-off for us because the more cardiac tissue we destroy, the better the durability of our procedure, but there is a higher chance of that destruction pervading the surrounding structures or causing collateral damage. So whether it's heat or freezing the tissue or using laser or ultrasound, we're always balancing that trade-off. In the last few years, there has been a technology called pulse field ablation, which has made its foray into our world, and it offers us the chance of mitigating collateral injury, which has made it very attractive. And the way it does that, we don't really understand it, but we know that it's cardiac selective. So it doesn't affect the nerves, the blood vessels, the food pipe that sit around the heart. The Heart Rhythm Society 2021 key highlights for pulse field ablation, where I moderated this session, was that this technology, the safety and efficacy, short-term, are indisputable. But the question is, do we get the lesion depth? Do we get what's called transmurality across thicker areas of the atrium? A group presented reassuring data that they did get good depths in thicker areas of the atrium. Another thing I find really exciting about pulse field ablation technology is a lot of these patients get remapped to check for durability. And I think that further adds to our level of confidence because certainly most of us agree it's very safe. The question is it durable in the long run? And the remapping data is an important part of that element, although it's quite an arduous process to bring patients back for that. There was another interesting study presented by Dr. Verma and Haynes, where they looked at temperature rises with pulse field ablation, and they found minimal temperature rises, which also confirms that this technology is non-thermal. Our group presented on impedance changes and how impedance behavior in pulse field ablation, which is an electric field behavior, is very different from radiofrequency or cryoablation. And we can't really compare these two, given the different nature of energy delivery. Moving away from pulse field ablation, the other attractive studies in this conference, which has changed my practice, and I reviewed it in conference this morning with my colleagues, is that the East AF-NET study presented the heart failure subpopulation analysis. So the parent study had evaluated whether rhythm control option within 1 year of diagnosis bore better outcomes. And they have found that if patients are offered rhythm control by drugs or by ablation, the composite outcomes were 3.9% versus 5%, which was statistically significant. Parsing this out to the heart failure population, they found that the benefits were still just as strong in the heart failure population. But what's even more fascinating to me is that in the background of the Castle heart failure study, I was offering ablation a lot more aggressively to my patients, but the East AF-NET heart failure study showed me that the heart likes to be in sinus, whether it's in reduced ejection fraction or preserved ejection fraction. So HFpEF, which is historically a difficult condition to treat, does derive very similar benefit with rhythm control. The other way the study changed my practice was that the heart really doesn't care if it's drugs or ablation. So offering drugs versus ablation with the end goal of restoring sinus rhythm is important. Moving on to ventricular tachycardia ablations, I think the most meaningful study that changed my practice was the stroke VT study, where they looked at patients who underwent PVC and VT ablation, and it was a total of about 250 patients who then underwent an MRI, and we found that these patients had a higher risk of subclinical disease picked up on their MRI. Half of these patients were randomized to an oral anticoagulant agent, and the other half were randomized to aspirin. Now, it's important to note that currently we don't really have an indication for oral anticoagulation in this population, but the study showed a large signal for reduction in stroke, TIA events, and reduced MRI findings for patients who are on an oral anticoagulant. So I have a case coming up this Friday, and I'm going to use the results of this study and put the patient on an oral anticoagulant for a month based on the impressive signal in this study.